So after a prostate cancer diagnosis, what do you do? How do you regain your sexuality back, right? And that's a concern for many patients that have to undergo prostate cancer treatment. What's the process? Is there a penile rehabilitation aspect to it when even before the procedure, before surgery or radiation? How about afterwards? What does that process look like? Today's conversation is with the one and only Dr. Robert Valenzuela, and actually is a rebroadcast because, well, we were supposed to record and we couldn't get our schedules linked for the recording, but we have an excellent episode that we're rebroadcasting today because honestly, there's not a whole lot that has changed within the last year or so. My background has changed. If you're looking and watching on video, maybe I have changed, gained or lost weight, hopefully better looking. I don't know. Certainly not more hair, but the information has not changed. And he takes you through the journey of what is the process of a patient after prostate cancer treatment to regain their erections, all the way from non-invasive pills, devices, to then, of course, penile implants, in which we've spoken quite often here in this 4-part episode on sexual health. And he takes you through that journey. Dr. Valenzuela is one of the ones that's one of the most known experts in the world of penile implants, certainly statewide in New York, but even globally. He is now at New York Health, which is an affiliate of Mount Sinai, and is the director of the Genital Urinary Reconstructive Urology Fellowship there. He's also the assistant professor there. Please enjoy, once again, amazing conversation, rebroadcast conversation with Dr. Robert Valenzuela on penile rehabilitation after prostate cancer treatment. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor. Before we begin with our podcast, I'd like to thank our 2 sponsors for this month. Boston Scientific, leaders in penile implants through their technology, AMS 700. Ask your physician and practitioner on Boston Scientific's penile implants. And XY Vigor, Mr. Happy XY Vigor, leaders in dietary supplements for male health, and XY Vigor for male sexual health. Enjoy the podcast. This means a lot to me because I don't think that I would have been in urology and men's health the way I am now. And pretty much at this point, thank God, a thought leader in as it relates to integrative and holistic urology without you, because you got me started at your office in Washington Heights. It's over 20 years ago, actually.
I know, right?
So,
it's been a while.
So it is such a pleasure to have you on the podcast, man. And let's get started. So what happens is, I see guys, part of what I do clinically is that some guys see me as a prostate cancer navigator, right? So what that is, and so they come to me for the holistic side of things, but they have trust issues with doctors. They think that everybody has an axe to grind. So I'm like the quarterback, right? So
right.
I've noticed that with many of them who say, look, this is my PSA, my biopsy report is X. I think I'm going to do surgery, but I'm really concerned about sexual dysfunction. That means a lot to me. And I find that sexual function, I don't think is a no-brainer. I think sexual function is a big deal for men. And it's a big deal for men making the decision as to what treatment am I going to undergo? And for many of them, they don't choose surgery because of that. Now, I have to say that with patients that I see, we live in a bubble in New York. We are here in great institutions, Mount Sinai, Sloan, New York Presbyterian. I think these are just great doctors all over all these guys get great results after surgery in terms of men having the ability to regain function. Of course, it depends on many things, their sexual function before surgery, etc. So I guess what we can do is take it from the top in terms of, all right, this is a guy that definitely will do, and we can talk about radiation because there is a significant amount of
Sure.
sexual dysfunction or ED that happens from radiation therapy for prostate cancer. So if the information is different, let us know. But they're about to undergo surgery, radiation. What do these guys need to know about regaining their sexual function after treatment?
Well, I got to tell you, Gio, one of the biggest things, and I think my chairman doesn't like it when I tell them, but I tell my patients the truth. I have no vested interest in the choice that they make. I am not going to perform the surgery. I am not going to give them the radiation. I'm there to give them my expertise based on my experience of 25 years.
Mm-hmm.
I used to do a lot of radical prostates. I used to do over 120 a year.
Yeah.
So I've done over 700 radical prostatectomies during my lifetime. And then, little by little, robotics came on board. And so, therefore, I stopped doing the radical prostatectomies. But I learned a lot during those years. I learned to understand what the pathophysiology and what patients can expect after the surgery. So even in my hands, back when we used to do open surgery, we used to tell our patients your incontinence rate was going to be this number. Your erectile dysfunction rate was going to be this number. And I say that superficially because the numbers have changed.
Right.
Back in early 2000, back before the robot, you were looking at an incontinence rate of about 15 to 20%. That's very steep. In my hands, I used to have an incontinence rate of about 10%, and that's because I was trained by some of the top guys, and I used to have excellent results. But I got to tell you, with robotics now, incontinence rate, probably around 5%.
And the reason why that's important, actually, as we segue into ED in a little bit, is because if you cannot get your continence correct,
you can't function.
You're not going to worry about sex.
You're not going to worry. You're not going to worry about it.
Right.
It's secondary because it's quality of life issue.
Right.
It's a huge quality of life. So the fact that we've gotten that under control, it's huge. It really is amazing, and patients have done so well. And with the prehab and the work that you do beforehand, with getting them to do the exercises and getting them on the proper diet and lost weight, all these things really help post-op. And not only with the incontinence, but the erectile function. And that's why I start off always discussing urinary incontinence. Because like you said, if you cannot get the urinary incontinence under control, forget about the sexual function.
Right.
Because you're not going to be interested in it until that happens.
One more question as it relates to just the surgery itself. So you think, or that the robot itself, obviously the surgeon, but the robot has significantly in terms of better outcomes from urinary continence and even sparing the nerves in comparison to open prostatectomies?
Absolutely. We were in a pool of blood when we used to do these cases. Now, when you look at the robotic cases, everything is magnified.
Right.
It is crystal clear.
Right.
There is very little bleeding. One of the biggest complications of radical prostatectomy was transfusion rate.
Sure.
Patients used to get transfused not almost regularly, but I'd say about 10, 15% of the times.
Right.
Now it's very rare that a patient gets a transfusion. So the magnification, the techniques have evolved in a way that you approach the prostate in different planes. There's something called now with retroperitoneal or a space of Retsia sparing radical prostatectomy that really seems to enhance the visibility and be able to spare the nerves and get better continence rate because you get better bladder neck reapproximation. So absolutely the robot
that makes
changed.
me really happy. I remember when the robot came out because it's more or less when I first started with you.
Oh my God, you were that.
And so there was a lot of anti-robot, including people even from my own institution who still, not anti-robot, just doesn't do it. But I won't mention his name because he's
remained nameless.
remain nameless because he's my boss and he's giving me a great opportunity at NYU. But
the saying used to be is, oh, you're finding a procedure for an application. Well, guess what, buddy? No longer the case.
That's right. And the word, obviously, I'm not a surgeon. The word was also, it's just marketing by the Da Vinci company.
Yes.
It's just marketing.
Yes.
No, it's better outcomes.
Really
it really
has.
is.
Really has.
That's
Absolutely.
Great. All right. So the guy wants to, actually, we're going to reverse engineer this, Robert, if you don't mind. So they get the surgery. How can they best, right? So there's two things that I think happen. One is there is some shrinkage of their penis. And you could let us know how correct that is, and if so, by how many inches or so. The second thing that happens that they care about is like, can I get an erection? And what does and how can I do that? So obviously sparing the nerve. So go ahead and take it away.
So, Gio, let's keep in mind that the day you get the diagnosis of prostate cancer, you get erectile dysfunction.
Yeah.
And you know why that is? Because psychologically
Yeah.
you're traumatized.
Right.
And now you're dealing with a major stressor in your life in which you need to make a decision. Once you make that decision, life becomes so much easier. But during that period of time,
Yeah.
sex goes by the wayside, everything goes by the wayside. What I always
If before surgery the mind is at least 50% for that you need for sexual function, that is magnified after that diagnosis, right? Even be
100%
yeah,
right.
right, exactly, right.
So the first thing I tell my patients is, look, we picked it up in time. You're not going to die from this. Okay. The one thing that you have to keep in mind is, like everything else in life, you just got to take care of it and move on with your life.
Yeah.
And if anything happens, yes, like remember the Bionic Man, we have the technology. We can
Right.
rebuild this. And I could tell you that your audience will identify with this because, you know, it is the
They of
ejaculation.
age.
That's right. You remember that, right? We can rebuild you. We have the technology. And
Right.
that is the case. You know, now when we get into the erectile dysfunction, back when I used to do radical prosthesis, I used to tell my patients, look, sexual dysfunction is going to occur in about 40 to 60% of men. Okay, depending on your pathology, depending on your age, depending on your weight, depending on your sexual function prior to the surgery.
Yeah.
But in reality, now, you know, I was doing this back in 2000, between 1998 and 2011. The reality is that those numbers have come down drastically. Now we're talking about 15% of men. I mean, that's a huge.
Is it because better surgical outcomes? Is it
I,
because men are healthier? What do you think is happening there?
I think it's a combination. I think
Yeah.
now sexual medicine has taken off
Yeah.
so much so that you have people like you and like myself who can discuss with the patients and prep the patients before the surgery. Not only that, we're very aggressive and very much involved. In the past, when I rotated through Memorial, most of our patients went to see their oncologist, and that was it. They had their radical prostate. Their urologist was their oncologist, and they followed up with them. The oncologist is not interested in your sexual function, and they dabbled and they said, let's do this, let's do that. But the reality is they weren't dedicated to that. They were dedicated to oncology.
Right.
Now you have specialists, people who are focused on treating sexual dysfunction. So we've
Yeah.
learned so much, and there's so many different types of treatments that we can do, and we start right off the bat. I mean, the minute that catheter comes out, we're all over it. We're helping to try to help you restore your sexual function.
Actually, it's before the catheter
That's right.
comes out and even before the surgery itself.
That's right.
So can
That's
you
why.
talk a little bit about the prehab approach
Right.
to penile health after surgery?
Right. So being in a major academic institution, I see a lot of my patients for prehab. These are patients who have been diagnosed with prostate cancer. So a couple of things I take into account. Like I said before, having the experience of knowing their pathology is extremely important. You want to know what the MRI looked like. You want to know the grade of the prostate cancer. You want to know, yes, their BMI is going to make a difference, their diabetes, and of course, their surgical pre-intervention sexual function.
What's the minimum shim score that you think of that will help? So shim score is a questionnaire that every man gets in your urology
Right.
office. The highest you could get is 25, which means you function very well optimally sexually. And then 0 is 0. You don't function at all. What's the lowest shim score you found that after surgery that where they can regain, all things considered, spare nerves, healthy, low BMI? What's the lowest shim score you think that they can get away with and develop sexual function after surgery? Hey, friends. This month is our 4-part series on the Dr. Geo podcast on male sexual health. And with that in mind, I'd like to thank our sponsor, Boston Scientific. I'm so excited to collaborate with Boston Scientific, a leader dedicated to transforming lives through innovative and medical solutions that improve patients' lives and health globally. Erectile dysfunction, ED, it's a common condition affecting 1 in 5 American men as young as 20 years old and older. If you have ED, know that it is treatable with various options such as medical solutions, natural solutions, lifestyle changes, medications. vacuum devices, injections, and penile implants. Boston Scientific's AMS 700 inflatable penile prosthesis is a long-term treatment designed to closely mimic a natural erection, providing rigidity when inflated and a natural flaccid appearance when it's deflated. To learn more about ED treatment options, visit the link below, ED Cure, or ask your healthcare practitioner for the best treatment options for you.
So we got to take into account you can get a raw shim score without the use of any medication prior to surgery, or a shim score with the medication. So guys who have a shim score with medication at about a 20 are guys who can potentially recover their erectile function. Those guys that have a raw shim score without any medication above 20, they also have a very good chance, provided they have low-grade disease, no negative margins, bilateral nerve sparing, and they initiate rehabilitation and prehabilitation immediately, pre and post-op. So when we go to prehab, so the first thing I always tell my patients is, look, first thing you got to think about is that your cancer is not going to kill you. This is something that you just have to deal with, like I said before. Second of all is we start them with medication. Immediately, even if they have a perfect 25 score, I like them to get more nocturnal erections. And how do we do that? We know that we have medications like tadalafil or Viagra that they take at nighttime. So I tell I put all my patients on either 5 or 10 milligrams of tadalafil every other night so that they begin to get nocturnal erections. A lot of times these guys take it in the morning. It doesn't make any sense to take it in the morning.
Right.
Because in the morning, it was very funny because back in 1999, guys were taking the medication. They were sitting down to watch the baseball game and they come in, doc, this didn't do anything for me. I'm like, dude, if you're watching TV and watching a baseball game, this isn't going to work. It isn't like magic. You take a pill and it's going to pop up. And that doesn't work like that. So the idea
How do you determine, Robert, so Cialis versus Viagra, or do you just change? How do you determine which one you use?
I base it on bioavailability. The reason they call tadalafil the weekender is because of the length of duration, the half-life of the medication. So I like to put all my patients on tadalafil. If they can't tolerate it because of the side effects, then I'll go to Viagra or sildenafil.
5 milligrams.
But for the most part,
I have noticed almost no side effects. 5 milligrams. I think starting at 10. Right? Is that right? Have you seen side effects from 5 milligrams a day? It's the lowest dosage.
5 milligrams is low dose, and it really has minimal side effects. So if a guy has a shim score above 20, I'll put him on 5 milligrams every night at bedtime. Yeah. But the question is, why at bedtime? At bedtime, we have REM sleep cycle. Right. We get nocturnal erection. We get morning erections. Right. But, even if you have one REM sleep cycle, that's enough to get you to stimulate and potentially give you a morning erection. So you're stretching the penis. You're increasing the oxygenation of the penis. You're increasing nitric oxide. All these things are going to make a difference. Actually, studies have been made on diabetic patients that just on putting them on medication, even if they don't have any erectile dysfunction, really prolongs their erectile function and prevents, decrease in function over time. So that's one of the things that I start off with. The other thing is something very interesting.
How far, before you move on, before surgery do they need to start this regimen?
So usually it depends when we see the patient. As soon as I see them, I start them. Most of the patients are usually 3 to 4 weeks prior to their surgery.
Got it. One last question. Why does the pathology report matter so much? So let's just say that they have positive margins, positive seminal vesicles. Why does that matter as it relates to sexual function?
It's going to be a wide excision. It's going to determine the type of surgery you're going to have. And I'm not going to lie to you and say, well, let's do this and let's do that because, it doesn't matter. It'll still help you out. The bottom line is, look, the risk of you having erectile dysfunction is going to be that much higher because of your pathology. Because you're going to have positive
exactly
margins.
What that means is that you have to you don't know until you're actually there, right, in the body.
Right.
But that probably means that there's cancer around the nerve bundle.
Right.
And they're going to have to probably remove the nerve bundle if there's cancer around the nerve bundle. So explain the nerve bundle, if you don't mind, and let me know if I'm right or wrong with that assumption.
No, but that's perfect. That's exactly right. So the prostate, let's say it's right in the center. Let's say it's the root of the penis.
Yeah.
right? So imagine the base of the penis, right? And the nerves travel right under the prostate at 5 and 7 o'clock. They're traveling all along that base of the penis. And so what happens is when they're dissecting the capsule of the prostate, they have to try to peel the nerves away. If the cancer is close to the nerves, you have to sacrifice the nerves. You don't have a choice because otherwise you're going to leave cancer behind.
Right.
And let's say that the surgeon is trying to be nice and say, well, I'm going to spare the nerve and I'll take the risk. And then all of a sudden you come back with positive margin. You're going to get radiation. You're going to burn that area anyway. You're going to end up getting hormone therapy. You're going to affect sexual function anyway. And nobody's going to sacrifice your outcome or your ability to be disease free for trying to preserve nerves that may or may not function. So above all, the most important thing is to eliminate the cancer.
And you really only, so the MRI doesn't tell you much whether or not you're going to be able to spare the nerves. You're only really going to know once you're in the body and doing the surgery. That's the only time that you get to know, or is that not right?
No, not really. The MRI, the imaging now has gotten so good that we can really see the lateral extension and posterior extension. We can see into the seminal vesicles and get a pretty good idea if they're going to have nerve sparing or not. So for proper counseling, the imaging is extremely important. And sometimes with the biopsy, if you get any segment of nerve or you have neural invasion of the prostate cancer, then you know that there's going to be neural invasion at the time of surgery, and you're going to do a wide margin resection. So no, the imaging is very good, and it's telling. It can really give you a good idea of what you're going to do.
You have two nerve bundles, 5 and 7 o'clock apart from each other.
Mm-hmm.
Let's just say you can spare one nerve bundle. Is that enough? Is it like is it similar to having one kidney? You can function just fine with one kidney. Okay, is it similar?
Not as good though. Not as good.
Not as good.
Not as good. You may still function, but definitely not as good. And so you still have an increased risk of erectile dysfunction. But that being said, you need to look at a long term and see how the patients do. Some patients recover extremely well, even after having wide margin excision. It's surprising how some of these patients can recover because, you can have
with one nerve bundle.
Innervation. With one, yeah, you can see that.
Yeah.
So, it's not 100%. We don't say it's going to be 100%. So when I counsel my patients, I say, listen, the likelihood is that this is going to be your trajectory. This is what's going to happen to you, and this is how we're going to take care of it. So I let them know ahead of time.
What's the discussion like in your office when their concern is, look, Dr. Valenzuela, I'm not that big as it is, and I'm really afraid and concerned that once, if I undergo surgery, it's going to shrink even more. So question number one is, by how many inches does it typically shrink? And if I'm using the right units? And number two is, what's the conversation like?
It's a very easy conversation in a way that I try to explain to them that the shrinkage, first of all, occurs because of lack of use and ischemia, lack of blood supply. So when the penis is not in use, what you usually wind up getting is the penis retracts, you get decreased blood supply, and patients get depressed. They're incontinent, they just had surgery, they forget that their penis exists, and then they realize, hey, one day they wake up and say, yeah, I got to get this going again. So what we see is anywhere from 2 to 3 centimeters decrease in size, which is, I like to say in centimeters because it's going to be about 1.25 inches. Sometimes patients can complain that they've lost that kind of length. It happens more with patients with comorbidities, patients who are hypertensive, diabetics, patients who get radiation, because there's a couple of factors that are involved. Number one, yes, is vascular. Number two is hormonal. Okay. And number three is the quality of the tissue. So I like to compare the penis like a sponge, like when you wash dishes, right? You take a sponge, a brand new sponge, it's nice and it fills up with water very quickly. Take an old sponge, you see it's crackly and it doesn't fill up the same, doesn't expand as much. The tissue is still there. The tissue it's elastic and it's still there. But what it is trapped in fibrosis because it cannot expand properly. That's where the shrinkage is. It's not that we pull your penis and we make it shorter. Is that the elasticity is decreased due to the surgical trauma, due to the ischemia, due to the hormone manipulation. All these things wind up affecting the size of your penis. And naturally, if you don't, you lose it.
You lose it. So I tell patients this, and I just want to make sure I'm saying the right thing. I tell them, look, this is the first time since you were a teenager that you've never had a nighttime, you've never had an erection, a daily erection since you reached puberty. Because even if you don't know that you had an erection, you definitely had at least 3 to 5 a night under almost any circumstance. You got to be in very bad health otherwise, if that's not the case. But when they have surgery, that's the first time in their however many years that they haven't had a nocturnal or a nighttime erection. Is that the case?
That's true. For most guys who are healthy, especially when you get a 50-year-old or a 60-year-old guy who's athletic, who's healthy, who's had normal sexual function, it's a shock to the system. Yeah. But they're also shocked because of the surgery.
Yeah.
So now what we've learned is to prepare them ahead of time. They get them prepared to understand that as soon as that catheter, even before the catheter comes out, they're taking the medication. They're paying attention to their sexual organ. They're stretching the penis out. They're looking for circulation. And now I was going to mention there's a new toy that it's actually making I think it's going to make a big difference for our patients. It's what's called a FirmTech ring, which is, think of a Fitbit for your penis. Can you imagine that?
Okay.
You got it?
Is there an app? Is there an app associated with
There's an app for that.
And then, then what? So then it tells you about nighttime erections and things?
That's right. You remember back when I was growing up, when I was in residency, we used to do what's called a Rigiscan. And
exactly.
And this was a monster. You had to put these 2 rings on your penis and this piece on your leg. And then you had to sleep with this thing overnight. And then it would measure your erections during the night. Well, now there's a ring for you.
Well, no, wait. Before the rigid scan,
wasn't there
like tape or something around the penis?
The stamp
test. And if the tape broke, that was a sign. Right?
The stamp test. That's right. You put a roll stamp around your penis. That's right. So now we have a Fitbit for your penis. Okay.
That's hilarious.
And
it tells you what?
It is great. What you do is, it's amazing because they're still working on the technology, and I think it's going to go a long way. So what it does is you put it on, and what it does is it measures your nocturnal erection. It gives you the strength of the erection, the peaks, the number of erections, the duration of the erections, and it traps more blood in the penis. So therefore, it allows better oxygenation. So I tell my patients not only to wear it at night, but now what I'm doing is I'm having my patients wear it before the surgery so that they can see what their erections are like before the surgery. And then after the surgery, I tell them to wear it, and they keep wearing it, and then we compare the graphs before and after.
Is it commercially available?
Yes, it is. It's direct to consumer.
Why are they not sponsoring this podcast?
Dude, I told them about you. I told them this should be the case.
I mean, come on, man.
Every radical prostate patient should have one of these things on their hands so that they get to know their penis. Get to know your penis. That should be a show in itself.
Get to know your penis. Get to know your penis. What's the name of it again, Robert?
It's FirmTech. So if you Google it, you'll see it right there. And
FirmTech.
Yeah, FirmTech ring. So it is really amazing. It really works really well. And what I like about it is not only are they looking at measuring your erections, they say in the long run, they're going to be able to measure your oxygen tension. They're going to be able to measure the
blood pressure of your, everything.
Everything, baby. Even how you're sleeping, if you're sleeping standing up or sitting down. It really is a Fitbit. It really is. So
that's unbelievable. I mean, I'm not surprised.
I'm actually I'm going to be working on a study with prostate cancer patients, with diabetics. I'm going to be working on a study with that and look at also at the different types of therapies that there are, including just medication, including shockwave, Botox, all these other type of treatments that are out there. So
amazing. So we got the prehab done. Right. They undergo surgery. Let's just say, all right. Should we make the assumption that they will, if both nerves are removed, so both nerve bundles are removed, they really cannot get an erection? Something else.
Assistance.
Yeah. Right.
So
but surgical assistance.
Not necessarily. No, not necessarily.
So without 2 nerve bundles,
right, you can still get erections.
What can work?
Assistance. So when we talk about assistance, it depends on your blood flow. Let's say you have excellent blood flow. You may be able to get erection with high dose PD5s like tadalafil. You may be able to get it with getting 20 milligrams of tadalafil.
Really?
Using tadalafil every other night and then 20 milligrams on the day that you're going to have intercourse. You may get full enough. And now with this ring, they can actually potentiate the erection even more and measure it. So that's number one.
Okay.
Number two, there's a spectrum in this problem, right? So you have people who respond to low dose, high dose, and then we automatically go to injection for a lot of these guys. What's called
Tell us about the injections.
So there's something called Prostate or there's also Trimix, which is a combination of different drugs to help you get erections. And these are injections that are injected directly into the penis. I know it sounds really scary, but I got to tell you, it's like diabetics inject themselves all the time for their insulin.
Sure.
So therefore,
but not.
no, don't give me that.
Come
Don't
on,
give me that.
diabetics inject themselves around the abdominal area.
It is
a little bit different.
It's a mosquito bite. The needle is very small. It's a 28 gauge. It's smaller than. It's like a pinprick. There it goes, a pinprick. So it's just a pinprick in the prick. That's all it is. But really, honestly, once you get over the phobia of the needles, it really is very, very effective for these patients. And the earlier they started, the better, because it maintains the oxygenation of the tissue of the penis. It allows them to get the elasticity back because you're getting the stretch in the penis constantly. Right. All those things make a huge difference. So what do we do?
Now we're talking, this is not prehab, no, this is after surgery.
So let's say after the surgery, now you're coming in, your urine is pretty much under control, or it's still not under control. We start working on your sexual function anyway. Even though a lot of the guys, I'm not really interested. We're like, it doesn't matter. Once your urine is under control, you will be interested. Yeah. So keep in mind, regardless of whether you're interested or not, you got to keep in mind that once you get over the trauma, you're going to want to get back into action, because every guy does. And that's what testosterone does to us. So at that point, if they start early enough, if they start doing the therapy, what we do is begin to measure the dose that they use. And if they begin to get a very good response, we begin to scale it back. If they're not getting a good response, then we may increase the dose to get them to get a maximum.
With the Trimix, with the injections.
Yes. And using in conjunction with the medications as well. So we like to use the terminology multimodal approach. Yeah. It's not just one thing does it all. Yeah. No, we want to use everything that's available.
I'm super excited about today's sponsor, which is Mr. Happy XY Vigor, a formulation to enhance testosterone levels and promote sexual function. Mr. Happy XY Vigor, or XYVGGR, was formulated by yours truly to optimize male hormones and free up testosterone and improve sexual health. It has an abundance of L-citrulline, which helps dilate and open up blood vessels so there's more circulation going into the pelvic area for better erections. Try Mr. Happy XY Vigor today.
So there's other things that are out there that are available as well, especially for guys who are mild. Let's say you're responding to medication, but you're not getting quite the erection that you want. Well, there's also Shockwave. And Shockwave has been shown to work in guys with mild erectile dysfunction. And what it does is it causes angiogenesis, which means new vessels that grow into the penis. It causes neurogenesis, which means that the nerves begin to regenerate within the penis. And those are very, very important for recovery.
And we're still talking post-surgery, not just organic ED.
Yeah, it's post-surgical.
Yeah. Post-surgical. So shockwave therapy is a viable option post-prostatectomy, assuming that they're continent, they have no urinary problems.
No. Shockwave can be used even if they have urinary problems. The only caveat is that they need to have erectile function. Shocking a penis that has no erectile function is not going to work.
Got it.
Okay? They need to have some response. I say they need to have a shim score of at least that's detectable, 14, 15, preferably 17 and up. Right. Those are the guys that are going to benefit from Shockwave. Doing Shockwave on a guy who has a shim score of 10, which is, halfway down the road, it's not going to work. It's a waste of money. And that's something that we have to keep in mind, is that this is out-of-pocket expense. So we don't want to subject our patients to an expense that's unnecessary.
Sure.
Okay.
All right. So we got that under control. So we have the injections, which, getting the dosage, in my experience, it's important. Because if the dosage is too good,
if
the dosage is too good,
too high,
then or too high, the problem is, of course, that they get an erection that doesn't become flaccid. And I remember, I forgot who I heard it, but that's an erection that's what, 2 hours, is it the the magic number that lasts for over 2 hours is a heart attack to the penis. So then that's a scenario where they would have to go to the emergency room,
Right.
and so forth.
So it's not quite a heart attack. It's more like having chest pain, and you're not having
Right.
the heart attack just yet. But 2 hours, I like to tell my patients 3 hours, they go to the emergency room.
Yeah.
At 2 hours, I tell them to call me. And
Yeah.
if at 3 hours they still have an erection, they need to go to the emergency room because you want to get treated within a 4 hour window. At 4 hours, it's a heart attack. And you want to get that penis down
4 hours, the
because
heart attack.
the longer it lasts without oxygen, the more damage it has to the tissue.
Right.
So therefore, yeah, we always begin with a low dose. We titrate all our patients in the office, and we keep in touch with them, and we titrate them very slowly in order to get them up to speed. That's why getting them, even while they're still incontinent, that they're not interested in sex, it's a great point. It's a great time because you can manipulate it, and there's no rush to perform.
Got it. All right, so here we go. Nerves may be, and is the approach any different with any other type of prostate cancer surgery, radiation, or any other type?
No, it all depends. Again, the pathology. If they have extensive disease and they have positive margins on the imaging, they're going to get external beam radiation that's going to be wide, and that's going to affect the nerves as well. So, my parents used to have a store. You know that. I used to work in a clothing
Washington
store.
Heights.
I always talk about wholesale because that's where it comes down to. You either buy wholesale or you buy retail.
Right.
Surgery is going to be wholesale. You're going to be whacked with everything up front. You're going to take the whole bundle with you, and you're going to deal with everything up front. Radiation is retail. It's a slow process.
Yeah.
The radiation may last 5 or 6 weeks, but in the end, that radiation is still effective for years to come.
That's right.
And the damage continues throughout those years.
Yeah.
So all those patients are going to have some level of erectile dysfunction down the road. It may not happen right away, but it will happen. That will be with radiation alone. But a lot of the patients who get radiation also get hormone therapy.
That's right.
And what does hormone therapy do? Hormone therapy is not what it sounds like, right? It's hormone suppression.
Right.
What it does is suppresses the one hormone that stimulates prostate cancer, which is testosterone. And what do we depend on testosterone for? Sexual function.
Sexual function and many
sexual
other things.
drive. Yeah, sexual tool. Building muscle mass,
Cognition,
bone strength, everything, all these things. And so all these other things are also affected. That's why you got to think very carefully. Am I going to spare my sexual function and go with radiation and hormone versus getting surgery and getting it out and maintaining my hormone levels? Very important decision to make.
Robert, I hope you have the answer. I know you will. You are. You've heard this before. Patients saying, listen, I'm getting an erection post-surgery. I'm getting orgasms. The orgasms are way more intense than before surgery.
That is awesome, isn't it?
What's up? It's almost like I'll sign up. Well, where do I sign up? What's up with that? How is that happening biologically? What's the biology there?
Well, you ever jam your finger playing ball?
Yes.
So what happens? Your finger's bent, right?
Yeah.
And if you try to straighten it out, what happens? It hurts.
It hurts, yeah.
Sure.
It
hurts.
Yeah.
Well, guess what? They just took your prostate, they left your nerves, your body's healing, it's forming a scar. As that scar forms, when you're having sex and the penis is stretching out, it's pulling up against that. And when you have an orgasm, what's the area that pulsates? It's the perineum, right in the bulbar urethra, that area. Yeah. And guess what? That area has some scar tissue that's formed. And sometimes that's so intense because it pulls on the nerves that it enhances that orgasm.
Because so the pulling of the nerve is what's enhancing that. So
it's really interesting, right? Because what happens when you have an orgasm? During sexual activity, you have what's called emission. Emission is the collection of semen within the prostate. There until you reach that point where you're going to have a sympathetic discharge and get an orgasm.
Not sympathetic, not meaning any sympathy towards anyone. Sympathetic means
you're ready to go, baby.
Part of the central nervous system. So it's part of the central nervous system. Okay.
I'm done, baby. That's it.
Right. There's no sympathy. Okay.
No, that's exactly right. So that's what you get. You have an orgasm and that bulbar urethra, that prostatic urethra squeezes down really tightly and causes ejaculation. So that's what happens during a normal sexual encounter, normal orgasm. When the prostate is absent, that fossa is empty. And although nothing is filling in there, you're still having that pulsation in exactly the same area where the nerves run.
Right.
And that area has been surgically altered. And so you have some scar tissue there as well. And I think that's where it comes from. And yeah, a lot of the guys say that their orgasms are very intense.
Very intense.
I had one guy that used to cry after every orgasm after his radical prostate. And that is no joke.
It's like I draw an image in my head, you know. It's like I see a guy like, you know, ejaculating and crying.
And
right
then
after,
in tears.
You know? That's great. So, all right. So we're moving along. So the injections may or may not work. They're ready to move on to something else. What else is there? So the injection may work, or maybe it doesn't, and they're ready to do something more aggressive. What else is there?
Well, you know, now the AUA guideline says you don't have to wait to fail everything. You can make a decision earlier on, depending on your potential for a full recovery. So let's say you're on pills and you're getting a shim score of 15, or you're getting a chubby. You're getting an erection of 5 or 6 out of 10. You're not satisfied with that. And you're scared of the needle. And even though you get a 10 or you get pain with the injection, you may go straight to surgical treatment. So the next step is, you know, we break it down into blocks. You have your normal, the guys who are on pills, the guys on injection, the guys that are in the middle that can get adjunct treatment like Botox. And we have spoken about Botox in the penis, which is pretty interesting, or shockwave. So let's say all of that happens. Well, guess what? At that point, if they don't want to deal with any of that, they come see me, because I'm the mechanic. I'm there.
Oh, they haven't seen you yet at this point?
No, not necessarily. They may see me for rehab, but for the guys who have failed, let's say for somebody else who hasn't seen me before and they need a prosthesis, then I'm the guy that they come to see. I'm the guy that's going to manage that.
So the penile prosthesis is the next and
the
final
ultimate,
stop.
Baby. It's the ultimate.
Next and final stop.
Yes.
We're going to talk about that in a second.
Sure.
Botox? Can we get 2 for 1? Can we get a twofer?
A twofer. Here he comes. So there was a study that was done that showed that Botox in patients post-radical prostatectomy and patients with erectile dysfunction had some recovery of function with the use of Botox. And especially in question 2 and 3, which is where they talk about question 2 on the shim score says, after the treatment, those patients that were able to get an erection, 70% of them were able to get a harder erection than the guys that got placebo. And then the guys that got, in the step 3 is how many were able to penetrate. Only the guys that got Botox were able to penetrate and maintain their erection, which is pretty interesting. So how does Botox work? Botox, what it does is it gets rid of the wrinkles. Well, how does it do that? What it does is a neurotoxin.
Yeah,
it blocks the nerves.
Botulinum is
botulinum toxin, the trait. And what it does is it blocks the nerves, prevent the muscle from contracting. Well, let's think about the penis for a minute, because that's all I do anyways, think about the penis.
Yeah, I'm surprised. You know, you have this beautiful background there, and I was hoping for some phallic shapes, but no, I don't see any, unless there's one within this painting there.
You should have told me, man. I would have brought some out. I was just at the Penis Museum in Iceland. I'll send you a picture.
Did you go?
Yes.
I had a phone. Interesting. So I had a telehealth phone consult with a patient who's American, but he was in Iceland yesterday, actually, and I said, oh my God, I haven't been. And it's like, you have to go to the Penis Museum.
Absolutely.
Like, in fact, he said, I'm going right after this conversation. After this consult, I'm going right to the Penis Museum. He did, actually. He said, I'll take a picture and send it to you.
I'll send you a picture of me at the Penis Museum and see if you can count how many penises are in the picture. But so the Botox, what it does is the penis lives in a relaxed, in a contracted muscle state. So the muscle of the penis is contracted at all times, unless it gets an erection. Then it begins to relax and allows blood to flow in. So what Botox does is, by injecting the Botox, it promotes relaxation of the smooth muscle, thereby facilitating blood flow into the penis. So it actually works pretty well in the right patient. Again, this is for patients with mild to moderate, not for severe patients. Very important. It's not for everybody. So let's say the patient fails everything. They decide they need surgical therapy. So what I do is, yes, I do penile prosthesis surgery, and I specialize in penile length preservation and penile length restoration. So
wait a minute. So that means that not only can they get an erection? And I remember, I mean, back when I worked with you, you were like the guy, and not only in the Upper West Side, but in New York. And they got an erection that they controlled completely with this penile prosthesis, and it goes flaccid when you want it to go flaccid.
That's right.
But you also get lengthening of the penis, which is one of the things that they're actually concerned about. So tell me more. How does that work?
So it's not lengthening. I don't like to say lengthening because that's a lie. It's length restoration. My goal is to help you restore some of what you lost. So we never say
how about girth wise?
That we can also, that can enhance, that increases. So we can increase girth with the procedures that we do. So so I specialize in that. Not only that, I want to make it look as natural as possible so that not even your partner can tell that you have an implant. So yeah, it is a mechanical system. It's 3-piece. Think of a breast implant that you put in. We put it in a place that you can't notice the scar. The scar disappears. There's a pump, there's a reservoir, and then there's a cylinder. And it's a closed system where fluid flows from one chamber to another, allowing the man to form an erection. Now, the one thing that they're always afraid of is it going to my desire, it's going to affect my orgasm. It's not going to affect any of those things. Think of a breast implant. When a woman gets a breast implant, they still have sensation in their skin. They still have normal sensation in their nipples. They still can lactate if they have children. Same thing with a man. Once implant, they're still going to be able to have sensation. They're still going to be able to have orgasm. And if they ejaculate, they can still get pregnant. So all those things are completely normal. The only difference is that instead of getting a spontaneous erection, they have to pump it up mechanically, get the full erection, and they're able to use it, and then they bring it down when they finish. The beauty about it is you can keep it up for as long as you want.
Long as you want.
That's right.
So premature ejaculation,
not an issue.
is never an issue anymore.
That's
All
right.
Let's unpack that just a little bit more. So there are several parts to it. There's 2 cylinders like shape that goes right into the cavernosum. These are the 2 muscles that engorges with blood that creates an erection.
It gives you the rigidity, right? The hardness.
It gives you the rigidity.
Right.
There is the reservoir that holds the fluid. What's the fluid? What's in it?
It's just saline. What's in it? It's just saline.
Okay.
Yeah.
Saline, and that reservoir lies between the bladder and your abdominal section. Is that how it works?
It's above the pubic bone. It's next to it sits next to the bladder or underneath the muscle, underneath the abdominal muscle.
And then the pump goes in your scrotum,
right,
somewhere between your testicles.
Yeah, posterior to the testicles, so you can't see it.
You can't see anything.
No.
This is a surgical procedure. And then once it's all said and done, you can't see anything.
Nope.
And the partner can't see anything.
Nope.
That's great.
They can feel it. They can feel where the pump is. But otherwise, for the most part, you can't see the pump. You can't see the cylinders.
And so to get it to raise the penis, they have to pump.
That's right. They pump it up.
And to bring it flaccid, they have to do what?
They just hit another button and squeeze they squeeze the penis, and the penis comes back down.
Comes down.
Yep.
Obviously, so what I've noticed is, bless you, noticed is they got to get over the psychological component of the whole thing. By the way, another surgery? I just had a prostatectomy. Another surgery? You don't see much of that?
I do. I see a lot of that.
Yeah.
But I also tell them is, well, if you want to resume your sexual function, you have a choice. So I like to compare it sometimes to like if you lose a limb. Let's say you break your leg and they had to take part of your leg off. You have a choice. You either hobble around, or you're on crutches, or you're in a wheelchair, or you get a prosthesis. Have you seen people running with a prosthesis? Have you seen how fast they run?
They run even faster sometimes.
They are great, right? And they look so natural. And a lot of them can wear clothes and they can't even tell some of them. Same thing, right? And they walk normal and everything. Well, the same thing with the prosthesis. Why not? If women, there's this whole phobia about this. If women could get breast implants, why can't men get their penile prosthesis and feel just as good about it and not be scared to say, yeah, well, that's what I have and it works and it's fine. And I got to tell you, the partners, they've done studies where they've questioned the partners. And I got to tell you, you're talking about 90% satisfaction rate on the part of the partners.
Wow.
So that's pretty huge. And that, in addition...
Well, PE, premature ejaculation, is a big deal. And I was only half joking before where if you suffered from that before and now you can last as long as you want, you could really be satisfying to your partner.
I think the partner satisfaction comes in two folds.
Yeah.
One, they see that their partners are back to their normal selves. Patients who get prosthesis are the happiest patients. You know why? They no longer have to think about an erection. They're no longer fixated that they can't get an erection. They're no longer disturbed by the fact that they can't get an erection and they can't function. Think of that. You want to have sex and you can't. And mentally you're disturbed. Why do you think you see all those grumpy old men? Where does that come from? Those grumpy old men, they couldn't get erection. They were frustrated. That's why they're grumpy.
And low T.
And low T.
Probably.
That's right.
Right.
So what happens is now you restore them back to their normal lives, and they can forget about it. In fact, they've done studies where men who get prosthesis, we're talking about 20% of men who get prosthesis, never use it on a partner. But guess what? 100% of them say they would do it again. Why? Because you've taken that element out of their lives. They can move on with their lives. They're no longer fixated on the fact that they are not sexually functional, and they feel less of a man.
That's very interesting. I was going to touch on that. Oftentimes men feel demasculinated after prostate surgery.
Absolutely.
So this is a method, perhaps, of them kind of getting their masculinity back to a degree or another, actually. Very interesting point. So this is a piece of equipment.
Yeah.
So there has to be wear and tear.
Sure. So
how long before there has to be a revisit where you have to replace the equipment?
So I tell all my patients the same thing. This is surgical. There's a risk of bleeding, pain, malfunction. Any of those things can happen along the way. But with proper use, once you get past the initial risks, we're looking at 10% at 10 to 15 year malfunction. And what we're looking at is at the age gap. Guys between 50 to 60 or 50 to 70 years old, they're the guys that are going to have about a 10% malfunction rate. Guys, they have a less than 5% malfunction rate. Why is that? Because the guys that have 50 to 60 or 50 to 70 year olds are going to be a lot more sexually active. The guys that are 60 and up, they're going to take a little bit. They're not going to 70 and up. They're not going to use it as much. So they're not going to wear and tear as much.
Not the guys I saw up in Washington Heights with you.
I got to tell you, okay, those guys are out there, baby. But it's true.
Not those guys.
But it does. The wear and tear is there. But I have guys who have prosthesis for 20 years and they're still going strong. They tend to proper wear and tear. It can be a very, very long time. But Geo, given a choice that they tell you, you're going to stay as you are, you're never going to have a normal erection again, or you can have sex for 10 years for as much as you want, which one would you choose?
Yeah, the latter for
Yes.
sure. And I think there's still a psychological what's going into my penis, but I think like everything with your penis, I mean everything with the way guys think of their penis, injection, the potion, they just very kind of you got to get over that hump.
That's right.
It sounds great. Now, lastly, before we wrap it up, guys on ADT. Look, interestingly, there've been some guys on ADT that I've noticed that, and I don't think they're lying. They don't have no reason to lie. That they said, look, I'm sexually active. I got married not that long ago before prostate cancer. Now I'm in ADT. She's young or whatever the case is. And I make it happen. And sometimes they will it or something with injections or something. What's your experience with sexual function after androgen deprivation therapy in terms of obviously desire is minimized, but guys that want to stay active?
Mind over matter. Guys are very visual. And if you see something you like, you can will it. But
can they see something they like and like it with no T?
Absolutely. Why not? I see a lot of guys just like you who have a testosterone of 0, of 1, and they still have the desire. They still have sexual desire.
How do you know my testosterone is 0?
Dude, I didn't say yours. I said guys that you see like you, buddy. No. Just like
what's interesting about that?
Excuse me.
I've done a deep dive in the world of naturopathic medicine and functional medicine. Just because I'm the only guy doing it, I don't think of myself as a genius, but I'm the only guy doing this one specialty. I've done deep dives into hormones in men. And two things. Number one is you need actually a decent amount of estrogen for libido and sexual desire as a man.
Right.
And I'm wondering that because most men would say this, they would say, well, no testosterone, I'm still somewhat interesting, but in a much different way. Mm-hmm. My wife or my girlfriend or whatever, or my mate looks interesting, and I do want to, but I don't know if I, it's a lot of psychological. So, but again, some of these guys on ADT make it
That's right.
happen. So do you do implants on these guys? I know
Absolutely.
some of these guys do injections. So
Absolutely.
what's your
The
experience
guys
there?
that are on ADT and they prolong or wait to get an implant, they're the guys that have the greatest loss of penile length because this tissue loses oxygen tension, number one, because of the lack of testosterone stimulation of the tissue, because it depends on testosterone for its function. So therefore, it becomes more crispy and fibrotic. And so it loses the elasticity. So they're more likely to get shorter penis and begin to lose length and girth very quickly. So for guys, so one of the things that I'm working with is patients who have had a radical prostate. Now they have a rising PSA. They have what's called a biochemical failure. They're going to need hormone therapy or radiation therapy. I tell them, look, you get your prosthesis before you get your hormone therapy to preserve your penile function and your penile length. So that's very, very important because it is essential for their function. Yes, they can make it happen and they can will it. And if the partner has a desire, they can seek it out and they'll be able to function because they have a prosthesis. And and remember, sex is not all about penetrative sex. There's also the intimacy. The intimacy that's associated with it. And if a guy can't get an erection, they don't feel that great about their intimacy. Think about being with a partner, even if you can't have penetrative sex, the fact that you can get an erection, you can be close to them and everything, that often is enough.
How many of those are you doing a year?
So I do about
penile prosthesis.
200 to 250 a year.
Jeez. Does that make you? I remember you were one of the top guys, certainly in New York. Does that make you still one of the top guys in New York?
I'm number two. What could I say? I'm still not number one. I'm working on it.
You got to work a little harder. Maybe after this podcast.
Yeah.
Maybe after this podcast.
Francois is still kicking my butt. If he's listening, he's still out there. But it's okay.
Still,
we're good friends. We love each other. We work very well together, so it's fine.
And I'm sure you guys learn from
each other. Absolutely, yes.
Listen, Robert, this has been an amazing podcast. It feels like it's just a conversation of you and I having coffee. So I appreciate it so much taking time out in this. Exactly. Where can people learn more about you and find you?
Valenzuela Urology.
Valenzuela Urology. Yeah, we'll have that in our show notes.
Very easy. It's all there. One of the things that we didn't talk about, but it's something that they're going to see there on the website. So I specialize not only in penile prosthesis surgery, I also specialize in Peyronie's disease. That's another podcast talking about the bend. And you got to get Xiaflex to sponsor you for that, buddy.
Oh, God.
Talking about the bend of the penis. So I do.
We could do one of Peyronie's, actually. I just saw a patient with Peyronie's. So I feel like I shouldn't digress like this, but it's just so fascinating. Again, it feels like we're having coffee. Peyronie's is curvature of the penis for those that are listening. And very briefly, it has nothing to do with prostate cancer. And, there's a whole natural protocol. So I've given up on these guys from a natural protocol perspective because it just takes too long and we don't know if it works. But lately, some guys that came back like after 5 years, because I lost them that didn't follow up. And so I don't know what happened. Some of these guys started coming back and say, Dr. Geo, remember the vitamin E that you got me on and the vitamin E topical and this, that, and the CoQ10? It worked. I just kept going at it. So it's actually very interesting that some of the natural things, which again, I've given up on it because I said, look, it's going to take so long. Most people are not going to continue. You're going to have to either live with it if it's a grade 1 and it's not a problem for you sexually and so forth. And then that is a conversation that we'll have.
Absolutely.
That is a conversation. Absolutely. But firm tech, I'm going to look out for those guys.
You got to look it up, baby. I'm telling you, this is every patient should have one of those things on.
Seriously. Yeah, seriously. If you have a Fitbit or an Oura ring,
there you go.
So this ring measures my sleep
there you
quality.
Go. Now you put one on your penis.
If you have a Fitbit, that's right. Robert, thanks so much, brother. I appreciate it so much.
My
pleasure. I hope to see you soon.
Likewise.
All right, man.
Cuídate.
Igual.
Take care.
Ciao. Thanks for tuning in to this week's episode of the Dr. Geo podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Geo Espinosa ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.